But I think we'll move on. And it's my pleasure to invite our next speaker, a close friend and a very talented surgeon, a multi-award winning surgeon, Dr. SUBHENDU BORAL from the Disha Eye Hospital, who's going to talk to us on something that he does. And it's very interesting to see his videos, RP choroidal transplants for choroidal neovascular membranes. So, Dr. SUBHENDU.
Thank you, Anand. Thank you, VRSI, for organizing such a beautiful webinar on this auspicious day after beautiful and very interesting talk of Professor Steve Charles. This is my topic, autologous RP choroid graft transplantation. So we know the principal causes of CNVM. It is AMD, PCV, and myopia. And the indications for surgical removal of CNVM are, if it is, I don't operate on the isolated CNVM cases. Usually, if it is associated with the large, markedly elevated, long-standing submacular hematoma, RP tears, hematoma not responding to the previous treatment, like subretinal injection of subretinal TPA, or hemorrhagic retinal detachment directly, like from ORA to orocereta. And autologous RP choroid full thickness graft transplantation is I am preferring in long-standing cases if it is persisting for more than 8 weeks. So the beneficial effect of CNVM and submacular blood removal, or the removal of the choroidal neovascular tissue, actually it completely removes the possibility of the rebleed, as well as removal of the barrier and toxic amount of the submacular blood. And rationality of the autologous RP choroid graft transplantation, because the RP is already, there is extensive damage to the photoreceptor as well as the RP cells in long-standing cases. And by providing the autologous graft, you are providing healthy autologous RP cells, and vitrectomy subretinal TPA with or without subretinal which may not work, and functional improvement may not be possible in these cases. So these are the simple like surgical steps. So I will come one by one, step by step. First of all, induction of retinal detachment to remove CNVM after doing cautery to the peripheral retina. You can do cautery, you may not do cautery because the peripheral retina is less muscular. After doing cautery to gain access to the subretinal space, I'm injecting BSS subretinally with the help of 38 gauge or 41 gauge cannula. Either it is polytip or metallic cannula. You can just lift up the neurosynaptic retina from the from the RP in a blob-like manner in multiple places, and you can do multiple times fluid exchange to unify it, and then can do the retinectomy to gain access to the subretinal spaces and come to the subretinal space. So if the retina is already elevated, like in this case, temporal 6 to 7 o'clock cross retinectomy directly you can do without elevating the retina, because the retina is already elevated. And as soon as you do the retinectomy, gas of blood will come out and do that surgery under airs. And then that it is time to remove the subretinal blood. Sometimes subretinal blood is very much like thick and clotted, so it is very difficult to remove the blood completely from the subretinal space. After removing all kinds of blood, you can just remove the subretinal neovascular tissue. And let me tell you one thing, that this neovascular tissue is sometimes very thick, just like nuclear remnant. You have to use frag settings using high suction and very low cutting rate. Now, sometimes this neovascular tissue are very fleshy. You can see the fleshy neovascular tissue. I'm removing it with the help of ILM forceps and with the help of this DDMS also, and remove the subretinal residual blood and do some gentle cautery to the feeder vessel to prevent the postoperative rebleed. Now it's a time for autologous RP choroid graft transplantation. After removing all kinds of blood, inject PFCL to keep the retinal flap away from your working area. And in this case, particularly in this case, there was associated choroidal detachment. So the case become easier for me because I am using cutter to lift up the graft from the surrounding choroid and translocate this graft under the PFO into the proposed site of the fovea, whatever it is there, and you have to remove the silicone oil, remove the PFCL after placing the graft, and then again inject the PFCL to settle the retina, do fluid exchange, and do laser after removing all kind of ooze, and after doing all 360 laser barrage, and treat it as a GRT, like taking care of the cornu cases. And do after removal of the PFO, you can inject the silicone oil 5000, and postoperatively patient is recently doing okay. So this is another case where after removal of the all kind of bloods, I'm injecting PFCL and choosing an relatively healthy looking area of RP. So did the cautery, little bit of cautery, and using bimanually with the help of Kurt's scissor, I'm cutting the graft under the PFCL. I'm just translocating the graft. Harvested graft into the proposed side of the fovea, graft realignment was done. Then you have to remove the PFCL and again inject the PFCL over the disc, and so that and start doing fluid exchange and do laser and finally silicone PFCL exchange, injecting silicone on the left hand and removal of the PFCL with the right hand under Chandler's light. So this is another case where I'm injecting PFCL to remove, keep the retinal flap away from your working area, doing some kind of gentle cautery, not too much of cautery, not too much of shrinkage of the graft is required. Now you can see the nicely graft has been taken from the place with the help of cutter as well as the forceps. So under the PFCL with the help of forceps, I'm translocating the graft into the macular area, up to the macular area, then remove the PFCL and again remove the PFCL and inject the PFCL over the disc, starting from the disc to reappose that flap, retinal flap, and start doing fluid exchange as well as laser. This is another case. It was very interesting thing. I previously treated the case with the help of vitrectomy with subretinal TPA, in this case of subretinal blood non-drainage technique. But after 14 weeks, the patient came with the massive recurrent subretinal hemorrhage. So in this case, I inject the PFA, TPA, and then did the retinectomy and remove all the blood. The blood was still clotted. Although I waited for 20 minutes time, but still the blood was not lysed properly. So you have to be very careful because a lot of adhesions can be there between the retina and the scar tissue. So you have to be very careful not to avoid the macular break and finally remove the silica, this CNVM. Then injecting the PFCL to keep the retinal flap away from your working area. And under the PFO, I'm just doing the cautery into the relatively healthy looking area, taking the large graft bimanually under the Chandler's light. And bimanually, you are shifting the graft considering its upside down manner and up to the macular area. And then graft realignment was done. Then remove the PFCL completely from the subretinal space. Then inject it again, just like managing GRT cases, inject it directly from starting from the nasal side of the retina, and then it is retina is looking nicely, and posteriorly patient can a good vision, like 6x16 vision from PR inaccurate stage. So coming to my experience, so this was a large submacular hematoma with vitreous hemorrhage, and posteriorly patient was doing okay after silicone removal. 53 months follow-up, patient gained 6x36 vision. This is another case, vitreous hemorrhage with the whole subretinal blood. Finally, patient gained 6x60 vision, logMAR 1 after 9 months of silicone removal. You can see that graft is gradually becoming incorporating to RP borate complex. This is another case, old submacular hematoma with vitreous hemorrhage. The graft is nicely placed and graft is gradually incorporating into RCC complex. And this is another case, cataract with large submacular hematoma but occult CNVM. But unfortunately, the patient developed a lot of excessive scarring subretinally going, and patient was having low IOP. That's why silicone removal was not done even after 6 months of surgery. This is another case, hemorrhagic retina detachment. Graft was doing okay, and it was USG also, ultrasonography also you have to do and to identify how much the hemorrhagic detachment is there. And this is another case, hemorrhagic retina detachment with large CNVM. Patient was doing okay, but still the IOP was not raised. I used silicone 5000 centiscope in these cases. And functional improvement you can judge from that multifocal ERG, although I have not done that microperimetry, but still multifocal ERG showed some kind of waves in all cases. And anatomical success, you can see the ICG showed revascularization of the translocated graft as early as 2 months. It can happen if something is before 1 month also. Thank you.
Thank you, Subhendu. Fantastic surgeries. Dr. Charles, your thoughts on this surgery?
Well, this surgery is magnificent. I have no personal experience with it. I've done a number of cases in pig surgery where we do induced pluripotential stem cells at the National Eye Institute and build an RPE on a biodegradable scaffold. So from doing that work, I've learned from the 50 scientists on our team at NEI that the peripheral RPE doesn't support the macula, that the peripheral RPE is the wrong kind of RPE for the macula. The late Bill Tasman many years ago reported that in ROP, ectopic maculas lose vision later in life, it drops down to 2200, 2400 without any new ischemia or scarring or anything else, simply because it's the wrong pigment epithelium. So there's a fundamental difference between peripheral RPE. There's some people in Europe that were doing iris RPE, which doesn't even support the visual cycle. So just because it's pigmented and just because it's there doesn't mean it works. And so that's one point. Second point is I've heard that others who have done the procedure that you outlined have a fair incidence of PVR. Carl Klass is an excellent surgeon, carries these the retinectomy all the way to the oral like you did, and he states, and he's honest, that has less PVR than if you make the retinectomy somewhat more posterior. But again, magnificent surgery. I've just the long-term visual outcomes is the question.
My only concern is the PVR incidence, Dr. Subhendu. What do you feel is the PVR incidence in your series? You've done a substantial number of cases, and how do you manage it?
Till now, I did more than 10 cases, so 11 cases, I think, yes. And one case, there was a development of retinal detachment. In 3 cases, there was persistent hypertony, maybe because of exposed RP choroid area. That's maybe I did the retinectomy a little bit posteriorly. That's why. It's not at that level of Oda, just Dr. Barbara Padovini was describing her technique. That was the situation. Otherwise, recurrent RD not developed. It is the PVR in one case detachment happened, recurrent RD, and ER formation happened in 2 cases. That in those cases, I removed the oil and ER formation. That's all.
Just one question from Dr. Charles. Where retinectomy is desired, what is your gauge preference, 25 gauge or 27 for a more controlled retinectomy? Because we are using 25 gauge mostly. Yeah.
I use 25 gauge. I've done several hundred cases with 27. It works fine for me, but I train fellows, and I find that the fellows have a tendency to bend the instruments to 27 gauge, and they of course the wound leaks are very rare anyhow, but less with 27 than 25. So if I didn't train fellows, I would use 27, but I do train fellows, so therefore I use 25.
There's a question from Dr. Chitranjan from Madurai. How do you measure the size of the graft? Do you have any, ballpark figure, or is it an estimate, or do you do anything specific?
There is no telltale criteria for estimating the. For me, Anand.
Yeah, sure. Yeah, for you.
There is no criteria. This is not standard criteria to measure the graft size. You have to judge it from the size of the CNVM. It is very large than I am used to do, because until unless is very large, there will be very large CNVM having very large kind of RP loss. So you have to take the larger graft. And if it is very small CNVM, though, so you don't have to use too much of cutter during the removal of the CNVM. That means small size of CNVM is necessary. So that you can only judge it after removal of the CNVM only. Yeah. So CNVM, because if it is large, then large size. On most of the situation, large CNVM are present. So that means the large size graft is necessary. And size of the graft, you can see it is 3 by 2 or 3 by 4. That size you can judge from the size of the disc, 1.5 millimeter to 3 times or 2 times, 2.5 times.
So yeah, my only comment, terrific surgery.
Anand, can I make an observation?
Yes, please go ahead.
Someday when we're talking about the gauge, I was just mentioning some of these cases, the blood is so dense and thick, and also the membrane, sometimes the CNVM is so tough that in these cases, sometimes we prefer to use 23 rather than 25, just because the 25 tends to keep getting blocked. And so sometimes we prefer, in these cases specifically, we say, let's use 23 rather than 25.
Yeah, my initial cases are on 23 gauges, sir.
Right.
Most of the cases are done in 23 gauge, not in 25 gauge. 25 gauge last 3-4 cases, 25 gauge. No case I have done it in 27 gauge, but most of the cases by 23 gauge.
27 gauge, the bending is the issue.
Yes.
So my only comment here was
Because most of the time the blood is completely different from the diabetic vitreous hemorrhage.
yes,
They're very sticky.
it's
and
leathery.
they are
Leathery. That
leathery,
CNVM
and it becomes
very leathery.
that cannula gets stuck with the cutter. It insinuates between the cutter and the cannula inside, and so it will be stuck. You cannot go inside, so you have to go out and inside and then go out, so that you can remove the you can loosen your cutter from the cannula.
Personally, actually, very often I've had to actually use a forceps and remove it completely. It's almost like it's as bad as cutting and doing a lensectomy.
Yes.
So my only comment here is that perhaps you need to actually move it right to the absolute periphery, as Dr. Charles also mentioned, to avoid previa. So thanks, terrific presentation. We could go on this, but considering